Ein herzliches Willkommen zu dieser heutigen Veranstaltung aus der Impulsreihe der Projektgruppe DigiWissMed. Christian Koop und ich werden Sie durch diese Veranstaltung führen. Christian Koop wird sich gleich auch selber vorstellen. Ich bin Niloufer Foadi. Ich bin seit 2006 Anästhesistin an der MHH und arbeite seit 2019 anteilig im Projektteam DigiWissMed. Wir sind insgesamt ein 6-köpfiges Team. Die anderen Mitglieder sind auch mit dazugeschaltet. Die sind quasi nicht per Video zu sehen, aber mit dabei. Und im Namen des gesamten Projektteams begrüßen Christian Koop und ich Sie zu unserer 4. Veranstaltung dieser Impulsreihe. Diese Veranstaltung zeichnet sich dadurch aus, dass wir einen kleinen Sprachenmix haben. Unser Gastredner ist aus Estland dazugeschaltet. Christian Koop wird ihn gleich genauer vorstellen. Wir danken Priit Kruus schon mal besonders, dass er sich dafür bereit erklärt hat, heute uns einen Einblick zu geben über E-Health in Estonia. Und obwohl der Vortrag auf Englisch sein wird, werden wir flexibel Deutsch und Englisch ein wenig auch mixen. Also bitte fühlen Sie sich frei, wenn Sie Fragen haben, entweder diese, egal ob auf Deutsch oder in Englisch, zum Beispiel auch schon während des Vortrags in den Chat zu schreiben. Wir sammeln Ihre Fragen und gehen darauf dann am Anschluss an den Vortrag auf die Fragen ein. Wir freuen uns natürlich auch, wenn Sie Lust haben, sich dann im Anschluss an den Vortrag gerne auch dazu zu schalten und live mit uns zu diskutieren. Die Gegebenheit ist, dass wir diese Veranstaltung aufzeichnen. Christian Koop wird gleich noch genaueres dazu erzählen und welche Bedingungen dafür vorgesehen sind. Dann wünsche ich uns allen einen schönen Vortrag und gebe das Wort an Christian Koop.
Ja, lieben Dank, Nilo, für diese tolle Einführung. Hello, Priit. Ich werde jetzt erstmal auf Deutsch kurz was zum Organisatorischen sagen, aber da auch gar nicht so viel Zeit verlieren, weil der Herr Priit Kruus sich extra dafür bereit erklärt hat, aus Estland sich zuzuschalten und uns zu erklären, wie digitale Gesundheit eigentlich funktioniert. Wie Frau Foadi schon gesagt hatte, die Vorlesung, diese Fortbildung wird aufgezeichnet. Das heißt, Sie haben jetzt noch die Möglichkeit, nochmal rauszugehen, Ihren Namen zu ändern, wenn Sie nicht mit Klarnamen auftauchen wollen. Das können Sie jederzeit machen. Wir werden die Fortbildung so machen, dass Sie jederzeit Fragen im Chat stellen können. Das heißt, hier unten links ist dieser Chat. Ich schreibe jetzt mal ein Wort da rein, Hallo. Da sehen das dann alle. Da können Sie Fragen entweder auf Englisch stellen. Die wird Herr Kruus dann, wenn er den Vortrag hält und diese Frage sieht, vielleicht auch direkt beantworten. Sie können die Frage auch einfach auf Deutsch stellen. Wenn die super passt, dann stellen wir die sofort dem Herrn Kruus. Wenn die Frage nicht so gut passt oder jetzt gerade nicht so aktuell ist, stellen wir die danach in der Diskussion dem Herrn Kruus. Das ist eine offizielle Fortbildungsveranstaltung der Ärztekammer Niedersachsen. Deshalb können Sie auch 2 CM-Punkte, CME-Punkte dafür beantragen. Wenn Sie MAH-intern sind und auf ILIAS angemeldet sind, füllen Sie dazu einfach in der Umfrage, die ich direkt nach der Fortbildung freischalte, Ihre EFN-Nummer aus, sowie Ihren Namen, Vorname, Nachname und Passwort, das ich Ihnen nach der Veranstaltung dann geben kann. Eine andere Sache ist noch, wir haben extra eine Evaluation für diese Veranstaltung erstellt, lassen auch ein bisschen Zeit am Schluss, damit Sie die ausfüllen können. Ich tue den Link dann auch in den Chat und dann können Sie kurz sagen, wie es war und ob Sie sich für das nächste Mal Verbesserungen wünschen und so weiter und so fort. Ja, das war auch alles zum Technischen, was ich Ihnen sagen muss. Jetzt geht's offiziell los. Priit, I will shortly introduce you in English and in German for a German audience. Und das werde ich jetzt auch tun. Ich werde Herrn Priit kurz auf Deutsch vorstellen, damit Sie mal wissen, mit wem Sie es ja eigentlich zu tun haben. Herr Priit passt nämlich hervorragend zu unserem Projekt DigiWissMed. Wir kümmern uns ja um die digitalen Kompetenzen in der medizinischen Ausbildung. Herr Priit Kruus ist der Leiter des Studiengangs Digital Health an der TalTech Universität in Tallinn. Der kümmert sich also nur darum, durchaus auch Absolventen aus der Medizin oder aus anderen Disziplinen Gesundheitstechnologie beizubringen und ist zugleich noch Mitgründer und Geschäftsführer eines Digital Health-StartUps, nämlich Dermtest. Die kümmern sich darum, einen digitalen Werkzeugkasten für Hauterkrankungen inklusive auch Wunderkrankungen bereitzustellen. Zudem hat Herr Kruus in der nationalen Telemedizinstrategie und der nationalen Strategie zur personalisierten Medizin mitgearbeitet, in diesem Zug auch viele Publikationen veröffentlicht. Das heißt, Sie werden ihn auch auf Google Scholar und auf ähnlichen einschlägigen Werten finden. Wer also kann uns besser über digitale Gesundheit aufklären und uns auch sagen, was eigentlich Ärztinnen und Ärzte oder medizinisches Personal generell wissen muss, um in der digitalen Gesundheit zu bestehen. So this was the introduction. Now we're going to switch to English, and Priit, I raised the bar a lot. I told them that you are a wonderful person, that you have a lot of competence from all different kind of fields. So the audience is very excited about what you're going to tell us, and yeah, I will just give you the stage, and then I'll come back after your presentation, which will last, I think, what do you think? How long will the presentation last?
Let's see.
Let's see, okay. And then is it okay if the audience asks questions in the chat and then you answer to them spontaneously? If not, then we have a discussion afterwards. Okay. Good luck. Enjoy, everyone.
Thank you. Guten Abend. Good evening. Thank you for the introduction and the chance to discuss with you and share my experience and my thoughts and my observation about digital health in Estonia. Digital health is definitely a really interesting field. Yes, sometimes I think maybe I shouldn't know. I should have been doing a lot of aspects and of things in this area and maybe focus on one thing. But at the same time, I think digital health and is something of a very interdisciplinary discipline, and there is everything comes together. So why I like digital health and why I like to innovate in healthcare is because it actually has, or it connects so many things of society. So you have the political perspective, the business perspective, you have life and death, you have everything. You have science, you have like user experience aspects. There's a lot of different fields come together, from medicine to communication to IT to political science to economics. So it's really interesting. And today I will try to share a little bit about my experience as a digital citizen in Estonia, as a citizen of Estonia, and how the Estonian digital health system, the Estonian e-health system, has been developing, and also, of course, what has happened recently with the COVID impact in terms of what impact COVID has had on implementing digital health. So 1 second. And okay, so digital health and telemedicine Estonia. So of course, the main goal of digital health is actually to lose the digital and have a seamless experience of life. Like we don't want to be in a computer. We just want to do those things what are on the video. We want to be with our relatives. We want to go. Maybe we don't want to go to a icy lake or a sea, but we want to enjoy life. And this is one of the most important things when we talk about digital health. We have to keep in mind that technology and digital technology in healthcare is a tool, not a goal, but it's a really powerful tool. And sometimes the tool can overwhelm the actual goals. So if I go forward a little bit of definition before, we talk about digital health quite a lot. Sometimes people say e-health. The scientists are also have kind of a disagreement there. Some international organizations have digital health, some e-health. But anyway, here is just a slight mapping of what I'm trying to talk about. So in general, e-health is something that that really includes a lot of different services. And when we talk about services, then I mean, let's say health information portals, clinical information system, digital prescribing system. These are kind of broader services, architectural services even. But there is also telemedicine, which means different kinds of communication. You have telemedicine between two health professionals, telemedicine between a patient and a health professional. You have telemonitoring, mHealth is somewhere here, video consultation, e-consultation, and so on. And all those elements have to be kept in mind if we talk about the landscape, and where actually I think Estonia has been good in is this blue part, and the preconditions of where this blue part falls. We have been also quite successful with the professional telehealth, telemedicine part, maybe not that successful with the patient and health professional telemedicine part. So let's see. But let's start from the beginning. So I can put digital health or e-health development into two kind of blocks in Estonia. The first stage, or two stages. So first stage being like building the preconditions of actually implementing a nationwide e-health system. And it all started in year 2000 when there was a public campaign. It was called Tiger Leap, and there was a strong push for internetization. That was in 2001. That was the second government of Mart Laar, who was also the first prime minister of Estonia. And in this year 2000, basically all the building blocks of Estonia were put in place during these years of 1999 to 2002. We secured the invitation to NATO. We secured the relevant basis work for going to the EU, but we also started this crazy project of building the X-Road, starting to make the ID card that would give a digital identity for every person in Estonia. And at that time, it was, of course, everybody made fun of that. Why do we need a plastic card? We have our wallets are full of different plastic cards. Like, what's it gonna do? But 20 years later, we know exactly why it is needed, or even 10 years later. So this kind of general digitalization also kind of went into the healthcare part, and then one of the biggest drivers were our sole health insurance fund. So we have just one health insurance compared to Germany. We have just one health insurance, which is quite independent, but at the same time quite dependent on the Ministry of Health, Ministry of Social Affairs in Estonia. And the health insurance wanted to start doing things more efficiently. And they started to use a secure platform called Toru, a pipe. And the pharmacies and providers had to start sending billing data and invoices to the health insurance through this platform. And the incentives were pretty simple. If you send your invoices for payments to the insurance providers and pharmacies, if you send them digitally, then you get the money in 2 weeks. If you send them on paper, then you get the money in 2 months. So everybody started to bring the billing data in on either first on either floppy disks and then later on through the Toro secure channel. So it was just pure efficiency. But this already built this kind of communication experience between the insurance fund and the pharmacies and providers. And in just 1 year, most of the providers and most of the pharmacies were connected. At the same time, the X-Road also had been started, and the whole transmission were kind of put on the X-Road already in 2003. And I will talk a little bit more what the X-Road is. Every Estonian should know this. And in 2005, 100% of medical invoice and prescription data was electronic. So no paper invoices and prescription data. So here we talk not about paper prescriptions themselves, but pharmacies and providers sending data to the health insurance fund to get money for reimbursement. So, and in 2006, another bold move, ID card was made compulsory for authentication for doctors and nurses and pharmacists, so that like you cannot use any more passwords. It's ID card. It's the two-factor authentication method, which was made compulsory. And this really built the basis of this ID card, right? So simple card, chip inside. And this really built the basis of the X-Road and so on, built the basis for e-health implementation. So the second stage was now more kind of focused and dedicated. There was actual e-health strategy formulated that we need to have countrywide e-health system, which has an EHR, so unified EHR. All the healthcare data should be sent to, should be put together, sent to one place. All hospitals should be connected. And then the relevant legal framework was established, so different public procurements, nationwide kind of onboarding and training, and what is important. So the national system was like an communication layer, but all the local information systems. So all hospitals had their own information system. They didn't have to swap the information system. They just had to connect to the central government framework. So in 2010 was a launch. So I will jump a bit forward here. So that's basically how the health information system works. It runs on X-Road, which enables secure data exchange between different government registries and different government information systems. It's open source data exchange layer is X-Road, and it enables to connect all the relevant registries the government has. So it's decentralized. There is no place where you have, let's say, population data and I don't know, general practitioners list all together. You have it in separate databases, but you connect them when you need to. So health information system is kind of is an architecture. It's not a front-end screen to the doctor. It's like a basic architectural layer. And here you have the different registries: State Agency of Medicine, Health Board, Quality Registers, Population Registry, Business Registry, hospitals connected. You have the picture archive, you have a certain health insurance fund registry, and relevant services supporting this, and also the patient portal, which I will show. So if I jump back a little bit, so what were the preconditions of all of this is the legal, technical, financial, organization culture. Always, if you do a big policy measure, then you need to have these preconditions covered. These are kind of self-evident. Of course, you need to have a dedicated organization. You need to have some kind of readiness to users, e-services to try them out. You have to have all the legal stuff ready and so on. So this was these are the self-evident ones, but also you have change management, which we talk about a lot in healthcare. You need to involve stakeholders at the right time to provide financial incentives for healthcare providers to adopt to change. You need to have standard settings. So what type of data is sent together sent to the health information system? The databases have to speak to each other. There has to be a roadmap of change and coordination, and there have to be enthusiastic people in actually all stakeholder groups, not just the government. There are a lot of enthusiastic people among doctors, among family doctors, among pharmacists. So everywhere there was somebody like, let's do it, let's do it, and even if it's hard, let's do it. So I think that was one of the important factors there was in the beginning of in the mid of 2000. Estonia was still kind of having this let's do new things attitude. I think we still do, but then it was right time for healthcare. And if we talked about the electronic ID card, and 70% of the people use ID card regularly, and many use also mobile ID, which is basically the same thing but in a mobile. So it enables two-factor authentication. And the STAR service, what we all talk about quite a lot, is e-prescribing. So because just in less than 3 years, the usage of e-prescribing jumped to 95% of all the prescriptions. There's no point of showing you further graph, because it has been basically 0 paper prescriptions for the last 10 years. And it's interesting because e-prescribing, it was also hard to start this. Some top officials also say that there was a meeting regarding e-prescription system launch when the media turmoil was so against the new system, because it has bugs in it. All e-health or digital system have bugs in the beginning. Or at least some bugs, at least some kind of not like bug is maybe a bad word, but like performance issues, too big, data load, and the servers didn't stand the chance. So, for example, on the 6th of, I think the launch was initially in the beginning of the month. And what they didn't expect was that there's a 10-time increase in prescription need on a certain date, on a certain day in month, which is the 6th day of a month. And the reason is, maybe some of you are guessing, is that it's the day when pensions are paid out. So elderly get their pensions. So and they didn't expect that the rate of how many prescriptions are issued or how many prescriptions are bought out at the same day as pension day, and the day after that it's tenfold. They didn't know this, so so that's why the system broke down at one point. And this is saying that the Prime Minister at that time, Andrus Ansip, said that during the launch of the service that, okay, this is the worst e-service there is in Estonia, we should shut this down. And 6 months later, he said that this is the best e-service we have. And now nobody has changed their opinion, but this shows that there's a hard part in implementing such broad change, because initially, sometimes at least in digital world, at least in these very complex digital solutions, some things don't work. And one of the reasons why it could not work is that because the architecture is complex. So what the prescription service, actually is, it's a service which connects different databases. State Agency of Medicine database has the information about which pharmaceuticals can be sold, whether the pharmacists have licenses, what are the reimbursements. The insurance database has the information whether the person is insured. The health board has information whether the pharmacist or the health professional who issues the prescription has a license to practice. And if the healthcare service provision, if the a hospital has a license to practice, so this all kind of connected together, and that's part of the beauty of the system, is that it kind of uses the existing resources. All the registries had to do some adjustments, but it wasn't just one big solution, but everybody had to do a little bit adjustments. Of course, some more, some less, but in the end, it all connected together. So that's the architecture of the electronic prescribing system. And what have the benefits been for the electronic prescribing system? So at the doctor's level, at the pharmacist level, at the patient's level, there are a number. At the doctor's level, it's different aspects. So reimbursement, you can select the right reimbursement. You can access the full medicine's history. You can see drug-drug interactions. Pharmacists they don't have to process the paper prescriptions. On this list, you don't have health insurance fund who actually saved a lot of costs for just so that they didn't have to process these paper prescriptions anymore for pharmacist reimbursement. And of course, the patient could get the prescription renewal at home. They didn't have to go to the doctor for prescription. They could be sure that they get the right level of reimbursement. And you, as a patient, you have the pharmaceutical history also online, what you can see. So and also the electronic prescribing system has been a policy-making tool. So I don't see an electronic prescribing system, which I did my master thesis on in 2013. I don't see it as a digital service. I think it's a policy change. And what it has also helped is it has helped to increase the ingredient-based prescriptions. So on paper, it's brand-based, but the health insurance fund tried to implement ingredient-based prescriptions. And here you can see the change of the share of them. And also now the health insurance fund has connected the electronic prescribing system with drug interaction kind of database, so that doctors can get alerts if there's a possible interaction between the drugs. So that's also what's kind of what is working right now, and especially important to GPs. So, but that was electronic prescribing. Now let's go to the health information exchange, which is that every hospital has to send digital documents to the central e-health repository. And this graph is really interesting because, as similarly to many, if you look at these different digital services, they have this kind of exponential graph. And here we have had the same. The green line shows how many documents, medical documents, epicrisis, ambulatory epicrisis, or whatever epicrisis has been sent to the health information system. The blue line is patient queries, and the red line is doctor queries. So what you can see is that initially data was sent there more, like 5 years or so, and then after this, the data becomes useful. They start using doctors start using the historical data more and more and more. So this is definitely like a really good service. You might wonder what's going on in this red area. So this I will show you. I will try to now switch my my screen to my so I will show you. So what I see as a patient. So this is a patient portal. I will let's see what health data I have. I could log in with ID card, but I'm using mobile ID. These were my ID code and my personal code, but now I'm getting request to enter my SIM on my mobile. So I'm entering my SIM or like mobile code or whatever it is. So two-factor authentication. I have to have my mobile and the computer, and now I'm logged in. So this is let's switch to English. This is my health data. The design is not new, and it's a little bit ugly, but it's okay. We'll manage. So here we have my who am I? Who's my family doctor? Here I have, like with red, this is a new thing. Coronavirus analysis lab results. Okay, I have recently zoom in a bit. So in August I did a coronavirus test. Let's see whether it's positive or negative. Yes, it says it's negative. Synlab, German company. So I did a coronavirus test, and yeah, here it is. And then let's see what else. So what I can see also is, of course, my healthcare data. So time critical data, like what I have here. So then I have let's say access rights. So what I can do is that I can close the access of this health data to different doctors, so that I don't have to like, if I want to. Most people haven't done this, but if I want to, then I can close it. There are other cross-border access to prescription data. This is also here, and emergency response center. I have a list of which doctor has looked at my data. Then statements of intention, whether I want to, whether I agree to blood transfusions, whether I agree to donating my organs. If let's say I have a car crash and I have perfectly healthy organs, and I allow them to donate my organs, but here I don't allow them to donate my my body. Let's say let's do this. If I want to donate my body, then I have to. I don't know how to change this. Okay, I can change it here. So if let's say I want to donate my dead body after my death, then I will have to just assign it digitally here with like I have a other pin code on my phone here. And so put my pin wrong. And of course, you can see here in the patient portal everything else regarding your previous visits to doctor. I would just want to see if this how this works here. Okay, signing in progress. Now it's signed, and I can always revoke my here I have it. Revoke my kind of doing. And what is also interesting, I have here the invoices. So I see the data, what the amount of invoices that health insurance has paid for my visits. So for example, here I have the COVID test invoice, which I haven't paid anything, but health insurance has paid it for me. But I can see and take a look of all the previous services and how much the health insurance has paid for my previous services. Like some GP services are with €0 because GPs are paid with capitation payment. Okay, so basically, this is the patient portal. Patients are using and getting more common to the patient portal. I have my case summaries here, which I can open and zoom in. This is like occupational health. This is a family doctor. Mostly visited a family doctor here. And so that's, I will switch back to the slides now. And yeah, then currently, according to the 2012 and 2018 studies, we top the charts in Europe with, especially with health information exchange and EHRs, not with telehealth. So 2018, first in EHR, and second in health information exchange. But when we talk about telemedicine, then we're fifth. What's actually going well in telemedicine is e-consultation. So a general practitioner can consult a specialist doctor, can refer patients to a specialist doctor with the consultation. There's a special forum for this. For every specialty of now it's already 29 specialties. If you make a referral, GP makes a referral to allergy doctor, then the allergy doctor sees the case first and then can decide whether the allergy doctor will take the case right now, whether it will take it in a few days, whether in a month, or whether the allergy doctor will provide a consultation to the family doctor and saying that, okay, you should carry on with the treatment yourself. So the use of this e-consultation is about right now about 6 to 8% of the whole ambulatory caseload. It's rising. I don't have the COVID data right now because I think it changed quite a lot during the last year. And the main goal of this service is that you empower family doctors, general practitioners. Not all patients go to a specialist doctor with very minor issues. You can keep the hard cases to the specialist doctors. The patient also doesn't have to travel. For example, if it's in a rural area, they don't have to travel right away to the specialist. Some treatment can be provided by the GP. And this helps to provide faster access. So the benefits of e-consultation, I think it's also a flagship service, is time efficiency, time saved also for specialist doctors, and sometimes for patients it's accessibility, it's quality, because the referral has to be with better documentation. It increases also trust to the primary care system, and I think in Estonia there is a pretty strong focus on primary care system and empowering the primary care system. I don't have an exponential graph here for this service, but this is yeah. So okay, now I have the slide about 29 specialties. I will bring an example here regarding like Dermtest, the company I helped to build. So what Dermtest actually does is it also enables this doctor-to-doctor e-consultations, and is supporting this national service of e-consultation with additional kind of doctor comfort layer, so that all the images could be, the medical photos could be shared with the specialist also in a really fluent way. Whether if photos are made at the office, then the Dermtest solution helps to add the images to the e-consultation, and the dermatologist and allergy doctors can consult based on photos. And the architectural layer of the health information system in Estonia, this runs on the government platform, but all the different services can complement this, such as Dermtest does, either for e-consultation or for just doctors and nurses using making clinical photos and quickly and easily, adding relevant data. And then this data can be included to the EPIC crisis and or the patient summary and sent to the national archive. So like all these different service providers can connect to the central system. And this is, I think, really important, that not everything from start to end is built by the government. The government provides like an architecture, platform, information exchange with X-road and standards set for the information exchange, and then the different providers can provide services, and it's really important that those providers have a clear understanding how to connect with the existing platforms. So if we talk about the success story a little bit, I think the potential is really important. The preconditions for Estonian e-health were really important. The e-governance system helped a lot, but I think also the dedicated goal setting is really, really important. Involving stakeholders, standards have to be set top down. Standards cannot be decided bottom up. And some incentive should be provided top down by the insurances, by the health information system, by the ministry. And there should be a strategy, a roadmap for small, medium, and big projects. But starting with small projects also helps. Small projects build examples. Small projects kind of build experience. People start in the system start understanding what the digital service looks like. And also this means that providing possibilities to smaller bottom-up initiatives, so that there isn't kind of like an approach that everything is done top-down, but there should be possibilities for solving the different smaller cases along the way. And of course, constant learning and testing. So like trying out IT is very, very complex because it's kind of like it's hard to grasp sometimes, and everybody in the system have to have a bit more experience what information system is. Otherwise, otherwise our hopes are built up with like super fluently working apps like Facebook or Instagram or like, but there are like tens of thousands of people making sure that each button is in the right place in these apps. And with health care, there are so many use cases. There are like thousands of clinical conditions or even more. and the expectation has to be lower in the beginning about whether things would work highly 100%. It should be about experimenting and doing the smaller things first and then building on that. I think this is kind of like top down and bottom up approach at the same time. So yeah, and leadership, simplicity, and focus. These aspects cannot be stressed enough. I hope I still have time, so I will share a little bit what happened during COVID. So far, telehealth had been lagging. Basically, in 2 weeks after COVID struck, or like came to Estonia, and there was a special situation declared in March. Basically at the same time, the health insurance fund then lift the gap from telehealth and started enabling those. And in the first month, these are actually months, but starting from mid-month, the share of telehealth visits was 58%. Then it fell due to this is summertime, and I don't know what's the situation right now. I should look this up, but yeah, it was definitely a very big catalyst for telehealth. And the learning points for the telehealth adoption was that, yeah, the adoption was really fast. It wasn't video what people start to use or doctors start to use. It was mostly telephones, but telephones could be supported with other visual solutions. So what were also the learning points was that laptops, microphones, cameras, all of these things had to be figured out, sometimes at home, sometimes in the hospital. So this was a bit of a mess. And the technologies what were allowed at this point was also every type of messaging tool. But yeah, the adoption was flexible, the satisfaction was high, and there's of course an understanding that telehealth doesn't substitute face-to-face, but is possible, but can do a lot in those cases when it's needed, because you have prescribing, you can just get the prescription all online. You have your patient history online. So if the doctor doesn't have to touch you or look at you very close up, then it's possible to provide the service, and this happened. And now the government has decided that this will continue. And here also I can bring an example of like how different digital health providers stepped up. For example, Dermtest built in basically 1 month patient telehealth support solution, so that all those phone-based telehealth solutions in one hospital could be complemented by a patient app, so that a patient could send their images to the doctors, and doctors could do the consultation on phone, but images were sent with like a special app for patients, and could be seen by the doctor. And in 30 days it was launched. It was a really kind of vibrating situation, like a good situation in that sense, that everybody was really open to implement all the solutions, and everybody thought long and understood that this is when digital health is needed. So this was a kind of like a silver lining to the whole mess of COVID. So now the government is going forward with remote monitoring and online therapy solutions. The insurance fund started innovation project, which actually has also taken the German model of Selektivvertrag as one of the examples, and German innovation fund projects, although we have done it in very kind of like much like a narrower way. But now there's a focus on remote monitoring and remote therapy, because everything else is kind of working and doing pretty okay. But I think remote monitoring has actually the most like also in scientifically the most benefit. But there is also a lot of change that needs to be happened to the financing model in order to for remote monitoring to work. So, and what also the government has tried to do is that if 2011, 2014, this was the mapping of, we tried to kind of map digital health into mHealth and telemedicine and e-health, then now the situation much more complex. And the government now adapted the insurance fund, they licensed the NICE evidence standards framework for digital health technologies, which enables to like evaluate and define digital health technologies based on the NICE British framework, and not look at whether it's telemedicine or whether it's an app or whether it's mHealth, but it's what are the functional aspects of the solution. So whether it informs the patient, it's simple monitoring, it's communication, whether it's patient to doctor, whether it's by voice, whether it's by text, whether it kind of treats, whether there is a doctor involved, whether there isn't. So this framework actually enables to map the evaluation need to different solutions and set the bar what evaluation is needed by different digital health services. Of course, if you have like an AI app which says the diagnosis based on some data, then of course this should be evaluated at the highest level. But if it's just communication, it doesn't have doesn't do any big calculations or inform a simple monitoring, then we shouldn't evaluate the digital health services in the same way as we do, for example, the pharmaceuticals. So this framework actually, I think, helps to make the digital health landscape much more clear and kind of like not getting stuck with the existing evaluation practices, which are built based on the example of common medical devices and pharmaceuticals, rather than take into account the 21st century technology. So healthcare, I think, still has an organizational buildup for 20th century technologies, but not for the 21st century technologies. And how to support all of this? So this, trying out new visioning, planning, training, supporting implementation, validating. This all needs people who know about digital health. And at TalTech University, we have a digital health master's program, which is an interdisciplinary program, and which goal is to train change managers for healthcare digitalization. So it brings together like people with very different background. There are doctors, there are nurses, there are IT specialists, there are engineers, I know biotech and economics and lawyers we have as our students. They come together and they learn together for 2 years straight. So they learn from each other, of course, but they learn also when I started, I said that the digital health is so super interdisciplinary. They learn this interdisciplinary field and in a really kind of hands-on and problem-based way. So for like, next week we have a program hackathon. They will start building their own solutions or own policy solutions, and the whole second semester is about like different types of project management. If some companies come out of here, then they can go also to different incubators and living labs. And also on the second semester of the master, or the third semester of the master's program, there is more focus on the science, and the students graduate with a published article and master thesis. But it's all in a very kind of problem-based format, and the goal is to have people that understand the complexity of healthcare, how these different parts interact. How, like, if you put an IT guy and a doctor in one room and hope to get back a good digital solution, then it doesn't happen. You need financing background, you need interoperability background, you need project management, you need customer involvement, you need the patient involvement, you need the ethics has to be thought about, the reimbursement, so on. So it's more complex. So like, we try to train people who understand the complexity and kind of fuzziness of the whole digital health landscape. It's really really kind of vague sometimes, and when IT specialists and doctors, they are quite used to think in a discrete way. So whether things work or not, whether the treatment works or not. But implementation of digital tools is kind of like an ongoing, flowing process, and this is something. This kind of understanding of that is something we want to train in this master's program, and also try to support the validation and training. So we do currently we're doing like a digital literacy training to half of the GPs of Estonia, and like a special program. We train hospital mid-level managers. We also build like methodological guidelines for telehealth impact and like remote care impact assessment. So that this was also done during COVID in May. We built like these telehealth solutions were put into use. We saw that, okay, we have to think about all the different aspects of this implementation, whether in which specialties it works, in which not, to kind of put some light onto this, and so build this kind of framework for that. So what's for the future? I mean, running out of time now, but what are the core things? So Garant is building an API for third-party services, so that different tools could connect to the existing health information exchange. If I have an app and I want this app to pull my personal data from which is about me for 20 years in the health information system, then there should be a secure API which enables to do it. And there could be very good services which can predict, based on my historical data, some of my kind of current conditions or so on. And then we have to make use of the biobank, which has 15% of the Estonian people's data. There are a lot of hopes there in terms of pharmacogenomics, but also personalized risk score, targeting screenings. And then we try to go over from we have to work with data quality. This is a problem, and so far the health information system has been on a document base, but we have to move to FHIR. We have to move to event-based model and make sure that the quality of data is much higher. The quality is there, but not enough for some type of research, for some type of services. We are moving to value-based care, paying for performance, paying for outcomes. This is also part of the remote monitoring project, where value-based care and patient pathway and monitoring technologies all put together and try to figure out how to implement this. And we have to keep in mind the once only principle we have in Estonian healthcare, meaning that data should be asked only once. So there's lots of projects, again, still happening, lots of enthusiasm. I think we need more evaluation and visioning. and more people who either in the master's program, which is, by the way, international program, and we have a number of German students also studying there, more people to come and evaluate what's going on here in Estonia, what we are doing, making use of the data. And I think we also now need more visioning. The big things have been done, but how to put the kind of the improvement of the whole system into a good visionary pathway. And thinking about financing and value-based care is also something that coincides a lot with the digitalization approach. Digitalization needs very good mission and very good targets to be successful. There's no point of doing things which don't make sense. Yeah, so thank you. This ends my presentation part, but I'm really happy to have a lot of questions and answer them.
Well, thank you so much, Priit, for this very impressive and very valuable presentation. And I think we are very looking forward to questions from our audience. There's already one from Professor Büchner. She asked, I'm researching digitalization from a sociology perspective. I'm wondering, is Estonia monitoring differences in the practices patients of different socioeconomic backgrounds develop to use their health data, maybe even with mixed method approaches?
It's interesting that you ask. We are just applied for a study for research to see why there are so big differences in digital health usage in different socioeconomic regions. The difference from the average can be 3 times. So, for example, in eastern northeast Estonia is 3 times less usage of e-consultation than in Estonia on average. And we have to look into this, whether it's health literacy from doctor's part, from patient's part, or whether it is somehow the implementation problem, so that if new solutions are implemented, whether the training is in a wrong way, or like I hope that I understand your question correctly. So please feel free to add questions or like rephrase also if that wasn't what you meant.
No, thank you very much. That was super interesting. Thank you for the talk and your answer.
And in general, did you observe or could you observe any other general observations regarding the health behavior of citizens in Estonia in the last 2 decades? For example, how often do they contact their general practitioner, or are there other characteristic alterations you could observe?
I didn't catch the question. I don't know if it's just my problem or like it was a little bit bumpy connection right now. Maybe you could also write it down, but somehow I didn't catch all the words.
Yeah, no problem. It's just about the behavior of the health behavior of the citizens in Estonia. Could you observe any characteristic alterations during the last 2 decades?
I think the health behavior is a whole different topic here. I think Estonia went through a rapid transformation in terms of economy, in terms of economic growth. Like the last 30 years, when we were one of the poorest countries in Europe, when we basically had to kind of lock ourselves out from the Soviet economic system and turn kind of 180 degrees our economy. That meant there was a really big hit in terms to the public health. We talk about alcoholism, different health behavior. HIV didn't get enough attention in the 90s, and there was a big problem in 2000. Yeah, some socioeconomic groups haven't got. So I think public health is something that has benefited from the digital health, but the opportunities for public health implementation are haven't been used that much until now. The focus has been like quite a lot still on the service part, but now the public health and now of course the healthy expected life years has risen a lot during the last 2 decades and last 5 years also, but it's really hard to make the connection of the different digital solutions and the rise in the expected healthy life years. I think this is very hard to do, but we'll see. Maybe somebody does good research on that.
Yeah.
Okay, more question. Yes. Okay.
Yeah. When it comes to data security and financing the project or the infrastructure, who should control it? Only the government? What do you think about the role of private companies in the e-health sector? How was the Estonian development financed?
Okay, there are a number of questions. Data security and financing of the project infrastructure. The project infrastructure was partly financed by the EU funds, structural funds, and the Estonian government, taxpayer money. No private sources for the basic infrastructure. And it's also held up with the government money. Data security. Patients own the data. I can go to the health information system and say that I want all my data about me, give it to me. I can go online to the patient portal or our state portal to see who has seen my data. I can close up my data. So that's a really important part in the. It's more about transparency and trust. The security aspect, there haven't been any leaks to X-Road. There have been some unique leaks of only for example, one GP practice, but for the central infrastructure, no leaks, no big hacks. And regarding private companies, yes, it's very important to distinguish what private companies are, whether they are specific solution providers or yes, whether they are like big tech. And right now, big tech, the biggest impact, for example, what Google has is that people first they Google their disease. So, but and I think the big tech is looking into digital health a lot now. Every big tech company is, and I don't know, I don't see that they will have a big role in the Estonian digital health infrastructure. Because because it's kind of like it's not built up in that way.
And for example, if a patient, I think every patient has the function opt out, right? If a patient doesn't want to share his or her data, does she or he has to take some disadvantages, or what do you think? Is there an alternative? Are there special?
Yeah, if they opt out, it's like their disadvantage is that some doctors are not able to see their data and maybe not able to provide so informed treatment decisions, or it will take more time for the patient to describe their medical history. I think that is a relevant kind of disadvantage. Otherwise, there is no disadvantages. It's just the system has to be responsive and good enough so that patients don't kind of close down their data, and so far they haven't.
Very, very good. So there's a lot of positive evaluation of the e-health. And for example, we have some other questions now. Marianne Behrens, she writes, thank you very much for an interesting presentation and the insights into digital healthcare. The question is, in Germany, some doctors consider it critical that patients have access to all their medical data because they could be overwhelmed by it. What is the experience in Estonia?
Well, as you looked into the patient portal, well, basically everything that the doctor writes goes there. So overwhelmed, I don't see the risk that people are overwhelmed by health data specifically. I think the people are overwhelmed by all the data, all the information, what we consume every day from media, social media, and everywhere else. I think giving health data like a very big kind of different role here. So recently, I think doctors have been talking about more and more how to talk with patients who have done their homework with Dr. Google. I think the transparency in this sense is better, that there isn't kind of a data monopoly on the health system's part. I think there is work to do with presenting the data. And I think there are now digital solutions coming which kind of make the patient's view in the patient portal. There's like the patient portal is 10 years old or even more. So they're thinking about how to improve the patient portal, how to support doctors in providing medical information in a more clear way. And I think here we are lagging behind. We're not doing this enough. But whether to close down the data in the portal, that I'm not sure, because we also need to have the interest by patients about their health, and data is one way to improve this, I think. But there are pluses and minuses. I mean, it's a hard question. It's a good question.
And besides the decentralized databases, I guess there are also centralized databases where the whole data are analyzed, for example, for research purposes. Is this right?
Using the data for research is possible, but it's not like analyzed for research purposes. You have to go through 2 ethics committees. Then you can make a data query for research purposes, but you can only analyze the data query, but you cannot do ongoing research analytics in the database. So there's a rigorous process for that so that what scientists have to do in order to use it for research purposes. They're trying to work on a way how to make it more easier to get the data for research, and that is secure and easy at the same time. But right now it's you have to keep in mind very many things so that you don't put out too much data, because if you put out too much research data, then you can start finding patterns and not make them anonymous again. I see there are a few questions in Germany. Some doctors consider it critical that patients have access to medical data. Okay.
We had that already.
Okay, we have that.
You are mentioning the big number of projects and the need for more visioning on your last slide. What logics are driving the growth of the infrastructure? What asymmetries do you observe at the moment? For example, are they focusing on easy-to-solve medical technical problems?
I'm not sure I fully. So the infrastructure now, the digital health infrastructure is partly also the digital government infrastructure. So there are different parts which are improved at the same time, like growth and built and improved. Yes, I think that sometimes I think that politicians don't understand digital health very well. And I think sometimes the political approach is to make something or build something with a lot of government money to show, but actually, like, what we need is to build the system more seamless, like less like fuss, more working in kind of the system working quietly in the background. And politically there is an asymmetry there, because you want okay, as a politician, let's bring out this solution for this thing and make a lot of press releases, but actually you might want to decrease the some kind of clinical problem 10%, or decrease the number of double queries, or increase the number of e-consultations. These don't seem to be so sexy goals. It's more interesting to say that now we will come out with an AI which will solve this. But I think that when there is more focus on the infrastructure building, then there is more. Then there is it's better focus. It's a better there is more possible positive benefits when you work on the bigger picture than these at the political level, those different tools. And here I think the private solutions are important. Germany's DIGA example is we are looking at this very closely. I think it's a really great approach. This is exactly the way how to involve private companies, but do it in a systematic way. And I think the government should exactly build this framework, how those apps will be financed, used, validated, included in the system. In Estonia, we would add the DIGA also, that they have to integrate it to the general health information system. But the approach should be about enabling and vision setting, rather than building everything on your own.
When talking about apps, you already spoke about it. So at the moment in Estonia, is it quite, or do physicians prescribe apps at the moment?
No, we have very few. We don't have app prescribing. This is lagging. There are very few apps which are reimbursed. And I think this is something what we need to work on also. So there isn't an app prescription list. So I think the strongest part is still this kind of central infrastructure which we have been building the last 20 years, and now it's time to exactly enable those additional services, either whether it's an app to be prescribed, or some kind of tool which generates patient-looking reports and describes patient health suggestions, and these kind of smaller things. But there isn't a one thing. There's lots that we have to kind of incentivize to be happening. And I think one clear thing there is also the financing and reimbursement change. We have to move towards value-based healthcare, and we have the first value-based healthcare financing measures now, and I think now the best way to go forward is to start reimagining how we incentivize and how we pay for healthcare, and then do it together with new digital health tools which help to measure outcomes in healthcare, measure value in healthcare, and also support the building of value in healthcare. So that it gets more complicated, unfortunately. but I mean, it's a task of all of you and us here in the same field to work on this. And it's like, it is complicated, but we have to work with it. It's possible.
And maybe a question regarding curriculum development. When you design the curriculum at your university in TalTech, how do you develop the learning outcomes, the learning objectives? Do you have interdisciplinary teams which define what the student should learn, especially particularly with respect to digital competencies?
Mm-hmm. So we have a kind of a small chasm here. The medical studies. We are not a medical university. We can collaborate with medical universities. We collaborate with nursing schools, but I think doctoral studies are not that well. Health literacy isn't that digital health literacy isn't that well implemented into doctor studies. If we design this master's curriculum, which is interdisciplinary, then we take a really broad approach and try to. We have a lot of cooperation agreements with the main players of the healthcare system, from the governmental, private, patients side, and have this kind of program kind of council and discuss it and make it kind of like a lot of get the people together and get them try out different things, because you can learn digital health by trying out. You cannot like learn it as a knowledge. It's different. You have to kind of throw the people into this unknown, because you start understanding what is building a digital health product if you try it out. And we try to build like a safe environment for trying it out in a student environment. So like this means living labs, so like simulators, kind of like we can teach a lot without actually kind of going with the stuff to the patients. But we can do a lot about like get them the feeling of how it is to build the digital health solution and who to talk to and so on. So implementing this kind of try it out and approach, I think this is the core thing, because mostly people who come to study, they really want to change the system, and they want to make the system better. So it's just our kind of approach is just to give them as much possibility to try out and learn by doing. It's hard to teach digital health if the context is changing all the time. I mean, like 3 years ago, it was a whole different thing. Now we have again different thing, and we have to redesign the curriculum basically on the go, like every year, every half a year. So that's, and you can do it. You can redesign curriculum every half a year if you leave a lot of flexibility into the system. So education has to adapt to the fast change of the society, and it's I mean it's kind of messy all the time. It's not fixed. It won't be 100% ready, but it's keeping the kind of the vibrant flowing all the time. This works, I think.
Yeah, it's very impressive. For those who are interested in the curriculum, use just the website, and I had a look. I think it's very it covers very different and very important factors. For example, when we look at the interface of human and technology, I think you have courses about the environmental factors affecting human decision-making and behavior, just as one example, and a lot of other very interesting courses as well, which we really need to have the future chance in a digitalized world. So we, if there are any other questions from the audience,
maybe I have one last very German question, because in Germany we have the ambulatory and the stationary sector. pretty much divided. Sometimes as a patient, you're not even allowed to go to a hospital specialist. You can only go to an ambulatory specialist. How is this in Estonia, and has eHealth changed this? Like, has it made it grow more together or made the system more whole?
It's the same thing in Estonia. You cannot go, you have a gatekeeper role at the GP. You cannot go even to ambulatory sector. You can go only to the GP. You cannot go to an allergy doctor just on your own. The GP will, you have to go to a GP, and first the GP has to make an e-consultation. So if they want allergist consultation, then the patient first has to still talk to the GP with the help of the allergy doctor, and maybe then they will be transferred. So it's the gatekeeper system. Of course, there's a somewhat parallel system for private. So you can pay and get to a specialist doctor right away, but I don't think it's not very big. And in the end, healthcare is all about triaging at the right level. So there is no point of me going having like a backache and going to orthopedist straight away. It doesn't make sense to me. You should go to the GP. GP refers you to the psychotherapy, physiotherapist, and maybe does an e-consultation to orthopedic doctor, and then you get the information, and maybe you need to go. So I think digital can make the triaging better and better, and the primary care, has a role there, has a big role there.
Okay, thank you. So digital health is like a facilitator for this kind of system where we have a gatekeeper, and only then, if the gatekeeper sees it necessary, you go further to more specialized doctors. Okay, cool. Thank you.
If there are no other questions, so we thank Priit Kruus very, very much. We really appreciate that you took so much time and that you gave us these very interesting and impressive insights. And we hope that one day we can also catch up. And since this is the last talk in this year, we wish you, Priit, and we wish the whole audience a very joyful Advent season, and despite the pandemic, please stay healthy and have a hopefully joyful time. Thank you very much, and have a nice evening.
Thank you so much for the opportunity.